And now we're going to move on to the management part of it. So this will be my suggested approach to any undifferentiated shock. To be able to manage an undifferentiated shock, you need first to recognize it. If you do not recognize what you're dealing with, you will fail to treat. So first, recognize that you're dealing with shock. And second, support the ABCD, just like what we always do in the emergency departments. And the third step is to identify the cause to be able to treat it. So generally speaking, management of shock should be directed at treating the underlying cause and to correct the physiological derangement. Regarding the ABCD approach, it is the same like any unwell patient. We're just going to focus on few things. So with the A and B, you would always give high flow oxygen. Remember that part of the shock problem is that the tissue are not utilizing oxygen, not getting enough oxygen. Give them more oxygen if you can, and consider intubation and positive pressure ventilation, because that will dramatically reduce the work of breathing and decreases the oxygen consumption. But remember, we've just listened to Dr. Ghanem talking about intubating shocked patients. It is not that easy. It is a high-risk procedure that you need to be very careful when you do it. Regarding the circulation, 2 lines of treatment. You give fluids, whether you're going to give blood or crystalloids, depending upon the situation, and you consider vasoactive drugs. And vasoactive drugs are 2 big groups of drugs. They're either vasopressors or inotropes. The inotropes are the drugs that will increase the myocardial contractility, will act on the heart muscle to increase the contractility to improve the stroke volume, while the vasopressors are the drugs that will increase the systemic vascular resistance. These are drugs that will cause peripheral vasoconstriction to improve the blood pressure. To understand how they both work, you'll need to understand the receptors that they work on. And these are the common receptors that we need to be aware of to understand the actions of different vasoactive drugs. So we have the alpha-1 receptor, and any drug that works on the alpha-1 will get vasoconstriction as an effect. We've got the beta-1 receptor that are in the heart and in the cardiac muscles, and drugs working there on the beta-1, the result is inotropic effect, so they will increase the contractility, will improve the cardiac output, and they also have a positive chronotropic effect, so the heart rate will increase as well. Beta-2 receptors, they are in the vessels, and drugs acting on them will cause vasodilatation and bronchodilation. And lastly, the dopamine receptors in the renal vessels, and drugs acting on them will result in splanchnic and renal vasodilatation. So these are the important receptors that we'll need to be aware of to understand the different actions of vasoactive drugs. So let's talk about the inotropes. What inotropes do we commonly use in the emergency departments for shocked patients? Commonest one is adrenaline. We also have the dopamine, and we have the dobutamine. These are the 3 common agents that we use as positive inotropic drugs in the emergency department. The adrenaline works by stimulating the alpha and beta receptors. So actually it has an inotropic action because of the effect on the beta receptors, and a vasopressor action because of the effect on the alpha receptors. The dopamine stimulates the dopamine and the alpha-1 and the beta-1 receptors. So again, it has both inotropic and vasopressor actions, and it also releases noradrenaline from the adrenergic cells. So the dopamine is a bit of a special one. It works only on the beta receptors, so it acts on beta-1 and beta-2. And the beta-1 action increases the heart rate and the force of the contraction. So it's a good inotropic drug. But the problem is the effect on the beta-2, it will cause vasodilatation. So this might drop the blood pressure. So that's why this is a very good drug to use in low cardiac output states, like the post-MI patients, for example, when the vasomotor tone is okay. So the problem is not vasodilatation, because this will not fix it. And also that's why we usually combine it with noradrenaline infusion, because the noradrenaline is a strong peripheral vasoconstrictor. So this will override the effect of the dobutamine on the peripheral vessels. So these are the important inotropic drugs that you will need to be aware of. Moving on to the vasopressors, we've got 3, we've got noradrenaline, and we've got the phenylephrine, and we've got the metronidazole. The noradrenaline works on the alpha receptors, so it will cause severe peripheral vasoconstriction. That's why it's a great drug to use in hypotensive patients secondary to vasodilatation. That's why it's the drug of choice for sepsis. But the problem is excessive use of it will increase the afterload and decrease the cardiac output because you're increasing the resistance against the heart. This will also decrease the renal blood flow and decrease the splanchnic blood flow and impair the peripheral perfusion. Regarding the phenylephrine, it stimulates the alpha-1 receptors, causing peripheral vasoconstriction. The metronidazole, I'm not sure if it is available in Saudi Arabia or not, but it is a very commonly used drug in United Kingdom. And the beauty about it is it works on the alpha receptors, causing peripheral vasoconstriction. So it supports the peripheral circulation and improves the blood pressure. But the bit about it is it can be given peripherally safely. So it's an easy drug to give, and you can give it peripherally. You don't need a central line to give it, and it works quickly. So that's why it's one of the preferred drugs to be used in UK as a positive vasopressor agent. So generally speaking, my preferred in a shocked patient, if you're not sure what's going on, is adrenaline. Get dilute adrenaline and give it peripherally. It can be given peripherally. You don't need a central line for this. And it's got positive inotropic effect, and it's got positive chronotropic effect, and it's easy and quick to prepare, and it's available in every single emergency department. So please familiarize yourself with adrenaline IV because it is a lifesaver. Some quick pitfalls regarding management of shock. So inotropes and pressors should not be used as a substitution for adequate fluid resuscitation. If your patient is empty, there is absolutely no point trying to squeeze them. Give them fluids. So fluid resuscitation first, and then start using the inotropic drugs. So please ensure that your patient is adequately fluid resuscitated first, and then feel free to use your inotropic or pressors agents afterwards.